Hello and welcome to UEG webinar. I'm your moderator, Imran Aslam, and I've been joined by Rodrigo and Bartomeu, who are our gastroenterologists and oncology colleagues. We will take you through some of our information sharing on a UEG platform and also serve you some educational purpose about colorectal cancer today. The reason we've chosen colorectal cancer because there's almost 50,000 cases of colorectal cancer every month in Europe, and we think that the services have been significantly impaired. So it's a timely webinar, not only to address the effect of COVID pandemic on colorectal cancer treatment, and also give you some idea how in future we'll be progressing. So let me take you through the format of this webinar. We will have a three presentation, starting from Rodrigo, who will give you an oversight of diagnostic services, especially focused on endoscopy. Then I will join in with a view of giving you the surgical treatment of colorectal cancer, how it's been affected, and how we're going to put them back on a track. And then finally, Bartomeu will give you a prospect of oncological and radiational treatment for colorectal cancer in this pandemic. Then the platform will open up for questions and answers. Whoever is appropriate expert will take up the question and answer you. You're encouraged to type in the chat box all your comments and views, and whether you have any contradictory views to our presentation, we will all welcome your questions. So I can see there's participants from Brazil, from Chile, Taiwan, UK. If you are from Eastern European country and from South Asia, like you are appearing on the screen, tell us what stage of pandemic you are, how it's affecting your services, and what would you be your views in terms of restarting or recommencing your elective work. So I'll take this opportunity to my friend, Professor Rodrigo Martinez, to take over the webinar and take you through the diagnostic pathways. Thank you.
Thank you, Imran, and I would like also to thank to UEG education team because for inviting me and also for the support for preparing this presentation. The outline of my talk is about. We will start talking about the activity in the endoscopy unit during the lockdown and how we have organized ourselves. Also about the potential impact of lockdown on diagnosis of colorectal cancer. And finally, we will talk about how to restart activity in endoscopy units. As you know, COVID-19 pandemic is hitting Europe very hard. And because of that, at the beginning of the pandemic, the European Society of Gastrointestinal Endoscopy said a position statement making some recommendation about how to organize the activity in gastrointestinal endoscopy units. For urgent procedures, we should do a patient risk stratification regarding the risk of COVID-19 disease. And for the majority of procedures, for elective procedures, we have to evaluate morbidity and mortality risk of GI disease versus the risk of the COVID infection. And depending on that, we can go to make the procedure, or in the majority of cases, we decide to postpone the endoscopy. For this reason, it has been a big decrease on the number of colonoscopies performed in our unit. For example, in our hospital in Alicante, in Spain, we have had a decrease from 50 to 90% of the number of colonoscopies performed. And that can result in also in a decrease in the number of surgeries, a decrease of the number of surgeries because of colorectal cancer of around 60%. This is that has been called the second wave of the pandemic. The first wave is the immediate mortality and morbidity because of the infectious disease. And the second wave is the impact of resource restriction on urgent non-COVID condition as, for example, colorectal cancer diagnosis in our case. What happened with these cases? Will the shutdown of endoscopy units provoke a state migration of colorectal cancer? That is a point that has not been adequately addressed in the literature. For example, we can see here the results of a systematic review and meta-analysis published in 2007 that found that there is no association between diagnostic and therapeutic delay and survival in colorectal cancer patients. This is somehow counterintuitive, but this is the result of the majority of studies are retrospective studies and subject of a lot of bias that difficult the demonstration of this logical relationship between diagnostic delay and survival. In more recent studies, for example, this is a study from Canary Island in Spain, demonstrating that in patients with symptoms that suggest colorectal cancer, allocating these patients to an early colonoscopy program improves survival in comparison with patients allocated to a regular or a standard colonoscopy program. And also in this other study, this is a modeling study in FIT-based screening colorectal cancer program, we can see how the longer the time between FIT positive and colonoscopy is, the more advanced stage colorectal cancer is diagnosed. So the COVID-19 pandemic is an opportunity for research this aspect because we can do for the first time prospective analysis about how this delay can affect the survival and the stage of colorectal cancer diagnosis. Finally, we have to restart the endoscopic activity, and for doing that, it is wise to use a prioritization matrix with some criteria for deciding what to do now, what to do next, what to do last, or what never should be done. In that sense, the Spanish Association here in Spain, the Spanish Association of Gastroenterology and the Spanish Society of Gastrointestinal Endoscopy have set indication that with different levels of prioritization. In priority 1, there are the indication with the highest risk of colorectal cancer, and that should be done first. Next, we have some other indication that should be done next, and we have indication that should be done last. In the majority of these cases, these indications are related to surveillance, for example, post-polypectomy surveillance or screening in familial colorectal cancer that can be also allocated to colorectal cancer screening programs. Another important point is what should never be done, because in that point where we have a lot of a huge backlog in our endoscopy unit, we have to look for inadequacies and to analyze these inadequacies in order to save some endoscopies. This backlog is impacting already exhausted endoscopy units, where the request for endoscopy will continue growing because in some cases the consultation has not been stopped. So there is a need to increase the endoscopic capacity because we are in phase of a real risk of collapse. It is very important to identify inadequacies and to intentionally look for common sources of inadequacies, such as post-polypectomy surveillance, family history of colorectal cancer, or in general surveillance of any type. This is what we did in our unit, where looking for inadequately indicated colonoscopies, we can save or reduce the impact of the backlog in our endoscopy unit. Minimally, but we can do something. Finally, I would like to explain a little bit about what happens with colorectal cancer screening programs. Most of these colorectal cancer screening programs in Europe have been shut down during the COVID pandemic. Invitations have been stopped, and some colonoscopies that were positive before the pandemic are delayed. These fit-positive individuals are waiting for their colonoscopy, and these patients should be prioritized when endoscopy units reopen. Because I have said there is a huge backlog of procedures in endoscopy units. So we have to figure out when and how to restart screening. Probably we should wait until endoscopy units have been alleviated of priority 1 symptomatic patients. Another thing we can do is to increase the cutoff for fit results in order to be obligated to be forced to do less procedures and more with more effectiveness. And we can also use fit results to prioritize the selection of symptomatic patients. In summary, COVID-19 has shut down endoscopic activity. There has been a decrease in the number of colorectal cancer diagnosis because of this stop in the endoscopy activity. That will provoke that future diagnosis of colorectal cancer could potentially occur at a more advanced stage, and this is an opportunity for research. We should restart endoscopic activity with prioritization strategies, and it is important the selection. What should be done first and what should never be done. For sure, the impact of colorectal cancer screening program that will be also very important, and it is an opportunity to restart wisely. Thank you very much.
All right. Okay, the next one is our Professor Bartolomeo Mazzuti. We'll discuss about the oncological treatment, and then we go in order for surgical treatment at the end. Over to you, Bartolomeo.
First of all, I would like to thank the UEG and also Rodrigo and Imran for the invitation to participate in this webinar. I think this is important to share point of view with different specialist implication in the treatment of, and the diagnosis and treatment of colorectal cancer. And so I try to summarize the point of view from the medical oncology mainly, but also from, I mentioned something about the radiotherapy, and because I will try to review the non-surgical aspects of the treatment of colorectal cancer. So, what is going down? No, sorry. Okay. Yes. Wait. These are my conflict of interest, and this is let me start. Remember the nature of the COVID infection, the COVID disease, because we need to face a disease with different phases. You can see, as I am sure you know, that majority of the infection could cause with a symptomatic course. The second will be mild symptoms, and some patients, and we don't know exactly what kind of patient, after being infected by the SARS-CoV-2, develop a severe infection, mainly pneumonia, and some of them recur, could evolve to ARDS with a cytokine storm, pro-inflammatory symptoms, and need critical care. So at the moment, we have no confirmed antiviral therapy, and the tools to face this disease remain basically within supportive anti-inflammatory and ventilatory measures in case of ARDS. From the healthcare system, the situation produce a shock between an increase, a huge increase in the demand of the healthcare service, and a restriction of the supply. So that is could be seen from many point of view, from the many angles, but at the end, we need to change priorities, and also we need to redesign the activities, but preserving the health care of our patients. And this is really important in case of the oncology patients, because as mentioned by Dr. Levis, is an American GI oncologist. They remember that the acuteness of infection and the chronicity of malignancies are the excellent characteristics. And the oncologists need to make a decision in a very difficult scenario. I think the goals of the oncology healthcare is to try to maintain the pre-planned treatment, supportive care, and follow-up, less in the last one, the follow-up. But we need mainly avoid stopping or delaying treatment, because if we do that, or we need to do that, probably we move to a loss of efficacy in the oncologic disease outcomes. We need to avoid delay, as mentioned before by Rodrigo, and because we need, the data has been mentioned before, but the delaying diagnostic of therapies or therapeutics finally will cause probably a loss of opportunities, but also an increase in healthcare demand, a deferred increase in the healthcare demand. So at the moment, also, we need to reinforce the support to the patients. The risk, on the other hand, in the other side, we know that cancer patients have an increased risk of infection. We are not sure exactly what is the risk for viral diseases. That probably is more well known, is better known for the bacterial infection and the fungi infection, but it's not clear that it's not so clear that we have not so clear criteria or predictive factor risk for viral infection. But anyway, the pandemic scenario generates an increase in urgent non-programmed hospital visit by the patient, by the cancer patients. And at the same time, isolation measures can cause fear of the patient and to ask for the assistance, and so delaying the time to respond from the healthcare. And the risk is we need also to preserve the safety of patients and the healthcare workers. That is the general measures what was being implemented in our hospital, a specific circuit for the cancer patient, control at the entry of the patient at the day hospital, where the patient received oncology treatment in outpatient basis, physical distancing between patient in the waiting room and in the treatment room. We need to specify circuits, and in case of fever, then the patient need to be assisted to another. They need to be referred to another part of the hospital. That really is the general measure: is protect personnel and patient, so using mask from the entry of the patient to this area, environmental measures, and also the social or physical distancing measures. But also we have implemented, before starting radiotherapy or chemotherapy, we are performing a PCR testing for COVID-19. But even that could be a matter of discussion, because the time of that, the validity of these results is very short on time. Well, these are the recommendations, the priority established by the European Society in Medical Oncology. High priority, continue treating the immediate life-threatening or patient unstable, and also prioritize the patient where the goal is increase the overall survival and maintain or preserve the quality of life. The outcomes only response rate, etc., has are a minor or a less important outcomes. The medium priority is the patient in non-critical situation, but we are facing the delay, and this delay could impact the final result of the therapy. And the low priority patient stable without symptoms, and we can delay the diagnostic on the therapeutic for this patient. We need to make decision in a very difficult setting, because we have a lot, I think a huge number of publication of papers. We have a lot of guidelines or recommendation for cancer patients coming from the different scientific societies, but we have not sufficient evidence or experience to establish guidelines. We don't know exactly the prognostic or predictive factor of the infection and the evolution of the infection by COVID-19. And at the same time, the guidelines recommend priorities, but these priorities has a low level of evidence. We don't know even if different cancer means different risk. And as mentioned before, the main goal is preserve the continuum of care. I think the tools for make decision in this setting may be the register or the surveys, approaching to real world data. We cannot await for the clinical trial results. So that is the scenario that we need to make decision for the patient. Moving to the issue of COVID-19 and cancer, there are recently the last weekend in the ASCO virtual meeting, the largest series of patients with infection and cancer was reported, about around 1,000 patients coming from US, Canada, and Spain. And in this series, okay. No? Yes. In this series, about 12%, not about 12% of the patient suffer gastrointestinal tumors, minority of them with recent surgery, and using or applying a multivariate analysis, the odds ratio for the 13-day mortality show that male sex is a major factor, a major risk factor for mortality. Comorbidities is the measure with a parallel increase in the risk according to the number of comorbidities, and the performance status. But if we move to the oncologic treatment, to the cancer treatment, cytotoxic anti-cancer treatment in the recent 4 weeks increased the odds ratio 1.47, and surgery in the same period is near the same, 1.52. So that means that the patient on treatment has increased risk of mortality. The patient with cancer in the active treatment, or surgery or drug treatment. And this survey recently published in Lancet, the COVID surge, also review more than 1,000 patients, and this odds ratio is similar. But for gastrointestinal, moving to the type of surgery or the type of cancer, the gastrointestinal surgery, that means GI tumors, really the increase is greater than other type of cancer. That is shown also in this review of the outcome of patients with cancer with the different different type of tumors. You can see in orange the disease, the fraction of patients that die, and if you this is the overall serious 25% of lethality, but if we move to the colorectal, 38% of lethality. Even in pancreatic cancer is greater, as you can imagine. And we move to the priorities in the treatment for chemotherapy on radiotherapy. We need to establish different levels, and in the up level, the high priority level is, I think we can agree that the complication due to the treatment or symptoms due to the recurrence or due to the progression related to the progression of the disease must be a high priority, need to be faced and try to establish treatment. The medium priority probably we can agree that is preoperative treatment in the rectal cancer. In the rectal cancer, that is clear, or adjuvant postoperative for the colonic cancer. Also, we need to establish a medium priority treating patient symptomatics in good performance status, first line, and second line if the patient progress shorter during the first line therapy. But because these patients need to be treated and need to be give the opportunity to improve the disease. The low priority, I think, is also easy to understand, is follow-up, and I think the low priority is also third line or more line of patients of treatment, because the improve of the patient in this setting is low. Let me address specifically rectal cancer in the neoadjuvant approach. As you know, there are two main pathways to treat rectal cancer: short course preoperative radiotherapy with a total dose of 25 gray, and this need to be followed immediate by surgery, less than 10 days from the first radiation fraction. That is the optimal in this way. The other way is preoperative chemoradiotherapy with the total dose of 45 to 50 grays, and concomitantly or 5-fluorouracil or capecitabine. And then the time to surgery is about 6 weeks after ending this approach, this preoperative treatment. I think some comments in this setting. Well, we can prefer preoperative radiotherapy, but we need to remind that the surgery could not be delayed in this pathway. The other pathway means that the patient need to go to the center more days, a lot of more visits or hospital visits, but we have more. Is easy to plan, and the time to the surgery could be wide. In this setting, I think is capecitabine, that is oral drug, is better than continuous infusion in the pandemic setting. Recently, also the past weekend, the neoadjuvant Rapido trial was presented at ASCO Virtual and show us that this experimental arm, short time radiotherapy, followed by full dose chemotherapy, is not inferior to the standard arm that is, as As you know, this preoperative chemoradiotherapy followed of surgery and followed by postoperative chemotherapy. Maybe this approach in this time, in these pandemic times, could defer surgery and could be adapt the healthcare system response. And if we move to the adjuvant approaches, as you know, the stage 2 disease, we need to know MSI status or use high-risk criteria with T4, less than 12 lymph nodes examined, and perforation, age, or DPD polymorphism. That is to decide treatment, adjuvant postoperative treatment in patient resected in stage 3. And if we move to the stage 2, if we move to a stage 3, then the treatment usually is oxaliplatin plus fluorouracil, continuous infusion, or capecitabine. One of the things need to be reassessed is the duration of this adjuvant treatment. As you know, 2 years ago, the IDEA collaboration was published at New England, put on the table the duration. We can treat only 3 months instead of 6 months. That was the previous duration of the treatment. And also, this has been updated in this ASCO virtual meeting and show us that for low risk, stage 3, probably the duration is clear, only 3 months. For high risk, if we use FOLFOX, continuous infusion fluorouracil plus oxaliplatin, then we need 6 months of treatment and is inferior to 6 months of capecitabine plus oxaliplatin. But even for high risk patient treated with capecitabine and oxaliplatin, then the loss of survival at 5 years probably is not clearly significant or is not relevant in the clinic. And the time to start adjuvant treatment is an issue that has been addressed by different meta-analyses, but in this meta-analysis, the delay of 4 weeks increased the hazard ratio for survival 1.14. Finally, the treatment, the systemic treatment with cytotoxic drugs is clear, is the usual in the advanced disease, but we have no data specifically about infection, viral infection, but we can assume that the risk of neutropenia or neutropenic fever could be related to the infectious risk. So we know that the combining 3 drugs, oxaliplatin, irinotecan, and fluorouracil, plus 1 biologic, bevacizumab or panitumumab, anti-GFR, then this is clearly increase the risk of neutropenia and the risk of neutropenic fever. So increase the myelotoxicity. So probably in trying to reduce the risk of infection of this patient, probably only doublets plus biological could be the standard of care in pandemic times. And also recently, the last weekend in ASCO virtual meeting, they has been presenting the first results in this specific subset, MSI high patient, where in first line in anti-PD-1 pembrolizumab immunotherapy was confronted with versus chemotherapy. And this clearly show an increase in favor of immunotherapy in terms of progression-free survival is double, has a ratio 0.6, increase in overall response rate, that is probably not the more relevant outcome, and a clear decrease on neutropenia. So we need to identify these patients. And in this patient, if we have one patient with MSI high, then nowadays the first line of therapy should be immunotherapy. And finally, let me show us three lessons, three learning I think this pandemic offered to the oncology healthcare. We need to rethink outcomes value of treatments. Probably one of the more developed tools has been the ESMO magnitude of clinical benefit scale in terms of curative or in terms of palliative. We need not only focus in the significant P, statistically significant, we need to move to the real value for the patient, of the benefit for the patient of this treatment. Also, we need to approach more to the patient, integrating the patient-reported outcome and trying to sharing decision. The important is not the response, is not probably the adverse event or the median or the hazard ratio. Probably the more important is the patient-reported outcome, the experience of the patient during the disease. And finally, I think we have opened and we have the technology to implement the telehealth information, and this, if we are able to connect this directly, the patient with the health, with the electronic health report, then probably we can clearly improve the quality of our care. And that is my last slide. I think the pandemic is a global crisis, as you know. But we can shape or reshape our healthcare system, also the economy and the social system. And we need to make a choice. Thank you very much.
Thank you, Bartolomeo. That's quite a nice overview. Actually, you covered some part of the areas which I was going to discuss, which I'm happy we can spare that time for further discussions. So let's move on. So my talk is going to be focused on surgeons and how the decision making will be made in the MDTs, and how we can move on from acute pandemic stage to a recovery stage. So I have no disclosures. I have no conflict of interest. Thank you, Bartolomeo. You almost covered the basics of treatments which we need to work on, and the principal strategies. The only thing I'd like to add on, we want to keep our patient safe, alive, and give them best outcomes throughout this pandemic. That's the whole emphasis of this treatment during the pandemic. So I'm not going to cover on this one. However, I'd like to touch on a couple of things. The priorities so far during the pandemic have been priority 1, symptomatic, acutely unwell patient, we need urgent treatments. And priority 2, asymptomatic, new diagnosis, or recurrent cancers have been pushed on its side. So I'll try to cover some of those areas as well, how we're going to bring them back. So recently, Royal College of Surgeons have established a checklist which tells us what sort of steps we need to do before we can recommence our elective surgery or try to come back to normal service. And this is a checklist given here. Let me put an arrow. So this is a quite extensive criteria. So obviously we want to make sure that the timing for recommencement of elective services is correct. The R rates or infection rates are low. Our ITU capacity is full and up and running, and there's not much pressure on it. And we have intensive care and support staff available. In order to resume elective services, we also want to ensure that there is a full access to PPE. We know that the guidelines for use of PPE is different in different countries and even different regions, but stick to the local guidelines, ensuring that there's enough PPE for emergency patient and acutely unwell COVID patient, and then start thinking about reconsuming your services. We also ensure that our intermediary services or independent services like pathology, radiology, anesthetic side not been overwhelmed, and they are returning back to normal phase. COVID testing, another issue. So the start of the pandemic, COVID testing was very poor in terms of numbers, but now the testing numbers are increasing in almost each country. So it almost becoming mandatory. Any elective planned surgery should have a COVID testing facility. We do 2 COVID tests 3 days apart, and also 3 days before the surgery. So bear in mind, it may be a same protocol in your countries. We also want to see what is our backlogs, as Rodrigo mentioned about the endoscopy. So there may be a huge backlog. There's 2 months of lag in terms of diagnosis and treatment, and nearly 1,000 patients will be in the system who will some stage start creeping into our current state. So that might overwhelm our capacity. We also want to develop COVID negative facility. There's a lot been talk around the world having a green site or cold site. So we're not mixing our emergency COVID services with elective services. Third capacity need to be thought in well structured. Remember that we're using more time to do the operation, more time to do the endoscopies, more time to spend with the radiotherapy regimes. So number of patients dealt in one session will be less compared to about 4 months ago. So might have to open up more capacity in terms of regional centers, private sectors, and tertiary centers. So a surgical workforce is important, that most of the nurses in theaters were redeployed to some of the areas, and some of them were off sick. They will be returning back to work. It's important that those sorts of resources are available. And next one is a point about local coordination, whether all these rectal cancers need to be done in a one unit or they can be centralized, whether advanced rectals need to be sent somewhere else. They have a high level of care there. And then the next step is we got plan and team in place in case we got a second surge. We would have a capacity to derail our plans. So the message is don't book your resections like 6 weeks time, because you never know that the second hit will be there. Both Rodrigo and Bartolomeo has discussed about the priorities. So I'm going into specific details of these surgical priorities. Again, the priority has been to operate on patients who are very symptomatic and need urgent life-saving treatments. So radiologically confirmed bowel cancer, obstruction, perforation, peritonitis, acute bleeding, post-operative complications, endoscopy-related complications, they all come as a priority one. We would like to operate on them within 24 to 48 hours. And that's what most of the hospitals have been doing through the peak of the pandemic. But there are some hospitals we've been lucky enough that resources were not overstretched, and they established clean sites or green sites, and they focused on priority 2 as well. As a result, their waiting list for cancers treatment has gone down. They're probably just waiting for new cancers turn up. And they also, the hot side have provided high priority services. But that model is not applicable to majority of the hospitals in EU and UK. And then there was a talk about low priority patients. For example, there was a question, those with a family history, those who have early rectal cancers, or there was those coming back from long course chemoradiotherapy, how to manage them. So those were categorized as a low category patient, low priority patients. So what we have done, most of the hospital in pandemic for early rectal cancer, if they have a facility, they will resect, otherwise delay the treatment. For locally advanced cancer, most of them were pushed into new adjuvant therapies. And if they are symptomatic, they get a resection. And metastatic cancers, again, they were all pushed to new adjuvant therapies. So that means there's a backlog of a huge number of patients who will come back into the surgical specialties for further operation or curative resections in near future. Now, there was a discussion earlier about the outcomes. I'd like to put a bit of timeline here and how the outcomes might differ. The paper I found, it was from Taiwan and from South America. What they have done, they have split the outcomes based on from diagnosis to delay in treatment. So patients who were treated within 30 days of diagnosis, they become standard, and those were treated between 30 to 150 days and over 100, more than 150 days delays. They analyzed and then predicted their outcomes. So here you can see those with a delay up to about 150 days, they have a significantly reduced survivals, even for stage 1, stage 2, and stage 3. And coming to one of the questions which were asked earlier, whether stage 4 will require a palliative chemoradiotherapy, why they're not been prioritized, or why symptomatic stage 1 and 2 been given a chemoradiotherapy. Maybe the answers would be here that the outcome didn't differ if there is a delay in treatment for up to about 5 months for that patient, stage 4 patients. And obviously, if we go beyond, the pandemic continues and we stretch it at more than 5 months, the picture is becoming more and more abysmal. The outcomes are further poor. So bearing in mind, I looked into another time. Like obviously, different countries have managed pandemic stage in different time scales, and the length of the pandemic might be a peak will be different. So there's another paper from South Australian registry, and I looked at in terms of diagnostic delays and treatment delays. So especially focusing on treatment delays, we can see if the delay was up to about 90 days, most of the survivals, early survivals, are not much different. But if anything goes beyond 90 days, even though the early survivals were not different here, but the long-term survivals were getting worse. So if a patient who had a surgery delayed for more than 90 days, the hazard ratio 1.24. Radiotherapy and chemotherapy as the primary treatment, it was further delayed. And overall, the hazard ratio 1.83 if the treatment is delayed for more than 90 days. So in short, by delaying the treatment, we might do harm to our patients. So this is another slide which Bartolomeo has explained, and I would like to give you perspective for 2 reasons. Because if we're planning for elective surgery, we need to bear in mind the mortality and morbidity associated with this surgery. So there's a paper recently published. It was a collaborative research group from Birmingham, which taken international data and looked at all the patients who had elective and emergency surgery, and they acquired COVID infection perioperatively. So obviously, if you look at this slide on your left-hand side, which divides the groups into under 70 and over 70, for under 70, we know that the COVID infection mortality is less compared to over 70. But the significant thing is that men under the age of 70, they had a high mortality. If you look at here, this is the minor elective surgery reaching the mortality up to about 10%. These are probably the fittest persons coming for hemorrhoidectomies or incisional drainage or abscess. They have, if they acquire infection, the mortality is up to about 10%. And for any major elective resections, if you look at here, it varies from 20 to 30%. So that means, whereas we've been quoting the elective mortality for anterior resection up to about 5%, now if they get a COVID infection, it's going to be 30% mortality associated with it. So I digged into a little bit more deep into this data, and I found this table quite interesting. For a generalized overall mortality for elective surgery was 11%. And if you dig into general surgery, as Bartolomeo mentioned, the overall mortality is 23% and morbidity is 53 to 6%. That means the risk of complication, especially the pulmonary complication, is very high, especially if they got acquired COVID infection after the surgery. So keeping in mind the delay can harm, on the other hand, we also have to balance out the elective surgery or emergency surgery might also kill the patient. So I'd like to take you through a bit of a diagnostic paradigm given by SAGES. So it's quite a nice flow. This SAGES describe phase 1, phase 2, and phase 3 of the COVID pandemic. Phase 1, which is I call it the green phase, where you still get a couple of patients in your hospital, resources are not stretched, there are plenty of ICU beds, and you've been allowed to open up the elective surgery. So if that's the case, what are we going to do with all these cancer patients we've been waiting? If there's an early cancer polyp or hereditary syndromes, or there's a carcinoma in situ, the recommendation is just delay until the pandemic is over. If it's early rectal cancer, especially T1 or stroke T2, we can offer them a resection, but need to be in a green environment. If there is symptomatic cancer, which I think fall into priority 1 as well, okay, we go ahead and do the resection. If there's asymptomatic colonic cancer, which is locally advanced, still resectable, okay, go ahead and do the resection. However, if there's a risk factors, especially in rectal cancers, where there is a circumferential margins are threatened, and there's a local disease which you cannot excise, the recommendation is actually go on to chemoradiotherapy, and if they've already been on that, maybe stretch the chemoradiotherapy further for further 12 to 6 weeks, and then you can have a further delay, okay, post radiotherapy. Now, this is almost like a priority 1. If there's a priority 1 patient, you should carry on treating. Supposedly, we get a second surge, and some of the hospitals cannot cope. The resources have been stretched. Might have to shift from a green stage to an amber stage, where if you go to a facility, you resect if you don't defer them. And that's almost coming back to our default position, that defer everything if you haven't got much resources. And most of us has actually gone through this emergency phase, which is phase 3, where we got no resources, PPE equipment's been scarred, and personal staff is also not been there. So a similar sort of guidelines has been produced by Association of Colorectal Great Britain. It's just to give you an idea in terms of decision making when you're sitting with these patients. So the recommendation is that if you're recommencing your elective surgery, you need to work on 3 areas, especially on patients. What are your surgical priorities? We discussed about priorities 1, priority 2. Okay, 1 and 2 must go ahead. 3 may be going ahead. And also assess for patient fitness as well as their vulnerability to get COVID infection. Now, the gist is that if they're fit enough, if they get a COVID infection, the mortality should be equivalent to somebody who's fit and healthy under 70. So if somebody has comorbidities, cardiovascular comorbidities, they probably fall into vulnerable group V2. And if they got somebody who can't walk about 100 yards and they have a chest infection, recurrent chest infection or cardiovascular risk, they probably fall into an extremely vulnerable group. And that means we're filtering on patients based on the fitness, where they can survive if they get any COVID infection post-operatively. We also need to make sure that the environment risk is reduced for these patients. So if supposedly, if we develop a COVID green side, which means there's no active infection in that area, preferably all the elective surgery should be done there. If you don't have a facility for isolated green side and you're still providing emergency care and elective services in the same hospital, it needs to be segregated. Practically, it's impossible because as a surgeon, you not only provide elective service, you also provide emergency service. So mixing emergency patient with elective patient sometimes is very difficult to segregate 2 of them. And then obviously, if you're going back to high prevalence where the pandemic peaks again, this becomes an unsafe environment for patients. So all these considerations should be taken in each individual patient's decision making before we proceed with surgery. There's also a recommendation that what should we do in terms of reducing the risk to the patient. So most of the hospital now are going on to 14 days self-isolation prior to the surgery. We, as I mentioned, get a 2 negative swabs for COVID. And in the past, the recommendation has been to do a CT chest for all asymptomatic patients. But the data now are coming and suggesting that actually asymptomatic patient CT chest is not significant. It will not alter your treatment. And obviously, it needs to be a multidisciplinary approach when you're making all the decisions. So this is almost a summary of what I just said earlier. So we want to make sure our resources and estates are established in a way that if we want to recommence elective surgery, we have a green side, a cold side, and we testing staff so the staff is not infected, not spreading infections. And as I mentioned, sometimes you have to compromise in terms of splitting your surgical teams into a green team and red team, and green team stays with the elective side, and red team stays with the emergency side and provide a separate service. We talked about a risk assessment in terms of patient vulnerability. Now, lots of hospital consultation gone to virtual. We still like to see our patient face-to-face, but if you can reduce face-to-face interaction, you can reduce the risk of patient getting COVID infection. So now most of the hospital gone into video consultations or virtual consultation, and I'm sure your hospital will be looking into it as well. We mentioned about COVID screening questionnaires and isolation and COVID swabs. I will discuss it a little bit more in slightly next slide. Now, when it comes to surgery, there's no clear data whether laparoscopic surgery is superior to open surgery or robotic surgery is superior to open surgery in these circumstances. The initial recommendation has been based on one paper that there is a presence of COVID infection into the peritoneal fluid, which was later on, I think, questioned. So laparoscopic surgery, open surgery, robotic surgery is equivalently safe, but it need to be assessed for patient status. If you're taking 10 hours to do laparoscopic surgery and 2 hours to do open surgery, the advice would be to do open surgery. So there's no real recommendation now which should be preferred. Now, as long as you have effective smoke extraction and aerosol evacuation system, laparoscopic and robotic surgery is safe. I also recommend that you follow your local guidelines for personal protection equipment. As I mentioned earlier, guidelines vary from one hospital to another one, and you must follow your own regional guidelines. In the early stage or the pandemic stage, anastomosis were not advised because of the risk of anastomotic leak and needing intensive care support. Now, if they feel that anastomosis is appropriate and patient factor has been considered into and discussed with the patient, anastomosis is safe to proceed. We also need to think how are we going to provide a post-op care. This is going to be different from in our normal routine. We had enhanced recovery, we wanted to get the patient moving, we want to walk around the ward, come back, relatives are coming in and encouraging, they go into a daycare unit where they have their energy drinks and they have a chat, but that's been limited now. They mostly spend their day in one room where they've been cared by maybe a 1 or 2 healthcare assistant assigned to that area. So the enhanced recovery is probably not going to be as go now. So post-operatively, we should also wear personal protection equipment when we're going to see the patient and minimize our interactions in terms of number of healthcare staff visiting people. Also, we need to be very vigilant in terms of managing post-operative complications. In the past, if somebody had a bit of pyrexia, it's always all basal atelectasis. They might have a rise in CRP, maybe post-operative related. However, we need to be really vigilant. If you get any symptoms of sepsis, pyrexia, we need to start thinking about COVID. And if in doubt, there is access to CT scan, do a CT scan, abdomen, pelvis, and chest, which will cover your whole body part. So also knowing in terms of post-operative pyrexia, how to manage it. Okay, I don't need to teach you on that. However, it's important that we keep in mind and keep testing these patients post-operatively for COVID status. Now, some of the hospitals now, with its resources available, COVID test is done on daily basis post-op, and is documented in the notes before the discharge. So I gather there is still ongoing issues. Some of the areas which we need more data and more clearance, like a pre-operative optimization, how they get that done at home and how they're done in community. Before that, they come to hospital, see the allied health professionals, and we optimize their status, but that's probably not feasible. So that's where the telemedicine will kick in. We discussed about the effectiveness in the enhanced recovery program. We might have to slow down on that prospect. And what we do with patients who are coming back, who have a resectable disease, and now they got solitary mets, whether they carry on with the chemotherapy, whether the plan changes. Also, the dilemma is how often you keep imaging them before you give them definitive therapy. If we're anticipating a second surge, we need to be careful that we plan our list carefully. Because if I said earlier, if you put a list 6 weeks in advance, you never know what will happen in 4 weeks' time when there is another surge. I already touched on robotic and laparoscopic surgery and smoke extraction. There are variations in terms of COVID testing. Some hospitals do swabs, some hospitals do antibody tests and blood tests. The sensitivity need to be considered. If the sensitivity is too low, that test will not be beneficial in terms of patient outcomes. And also, what we do in terms of post-op, we've been reducing the post-op appointments. We've moved on to telephone follow-ups. And if the consultation is required for adjuvant treatments, that also go through the telephone follow-ups. And we also need to probably refreshen our knowledge about managing pulmonary and non-pulmonary complications. That's from my end. So now the house is open for our questions. If I take the opportunity on behalf of the participants, there was a question about should we change the threshold for a FIT test for the purpose of diagnosis of symptomatic, asymptomatic, and screening?
It has been a lot of literature about how to select symptomatic patients for colonoscopy. There has been studies using the same FIT than for screening in the majority of countries, that is from 50 to 100 nanograms per milliliter. But there are other studies that consider any positive in FIT testing without cutoff for prioritization of colonoscopy. It has been also a matter of research. The proposal, it is not, it is just a proposal that is also in the scientific community, is the possibility of using FIT for selecting symptomatic patients for prioritization of colonoscopy with any cutoff, at least the cutoff that we are using for colorectal cancer screening.
Excellent. I would like to extend on, what are we going to do with this patient who had a family history and need colonoscopy and they're sitting at home and getting worried?
Yeah, I have seen the question. Probably I didn't express myself very well. I didn't say that we don't have to do procedures because of familial history of colorectal cancer, but we can select the procedures with the highest yield. And the real situation of risk that has been proposed by the Endoscopy Society of Gastrointestinal Endoscopy also are the patients with important family history. The risk cutoff for colonoscopy is having at least one relative younger than 50 years or having 2 or more first-degree relatives. One first-degree relative younger than 50 years or 2 or more first-degree relatives. The other people with other family history, not so stringent, can be adequately protected or prevented with colorectal cancer screening program, with the local colorectal cancer screening program that in Europe are on their majority based on FIT test.
Thank you, Rodrigo. There was a question about why are we choosing symptomatic patient and giving them high priority and giving them chemo and not the patient who will need palliative chemo. So why are we prioritizing them on that scale?
Well, I understand that the question was mainly related to the radiotherapy use. And I think the problem with radiotherapy, I think is the radiotherapy is a very interesting and useful tool, mainly to treat probably bone mets or some other metastatic setting. But probably when the main goal is palliation, the radiotherapy means that the patient needs to come to the hospital And that is in the trying to avoid and to reduce the visit to the hospital. Then I think that is the philosophy of the prioritization. It is better try to palliate using a pharmacological approach. Pharmacological, I mean analgesic, steroids, etc., trying to delay the use of radiotherapy for palliative. I understand that the schedules of radiotherapy can also be more simpler, more reduce the number of visits to the hospital if we use hypofraction approach. But the guidelines or the recommendation, better than the guidelines, state that probably the palliation using radiotherapy could be considered a low priority. The same for third line or subsequent line. I know that we have possibilities to use third line chemotherapy drugs that has been shown better than bed supportive care. But maybe in the pandemic setting, that means the patient came to the hospital, need to be perform blood test, etc. And at the end, that could cause that increase risk for the patient in third line when the goal of the treatment is only palliative.
Thank you. I hope that answers to Athnas McFerrin's question. Now, the question was, Bartomeu, that does immunotherapy impair your outcomes from COVID infection or worsen your outcomes?
That is really a burning issue, but I have no answer. But I think nobody have nowadays a clear answer. Even the immunotherapy approach has been considered in some way to reduce the burden of the viral infection. And some concerns have also arisen about if we use the immunocheckpoint inhibitors, could increase the risk of the evolution of the infection by SARS. But nowadays, I think nobody can answer this question. It has been has been published in Cancer Discovery 2 weeks ago. One series is probably the better paper on this issue, and the conclusion of this series is that the use of checkpoints inhibitors do not increase the risk of a poor evolution of the COVID. But the data are really few data. Is impossible to establish, to make a clear statement in this issue.
Thank you, Bartomeu. We're going to switch a question now to Rodrigo. It was like lots of endoscopy-related questions. So the two questions from Josie and Lex, all interrelated. Should we be reviewing our colonoscopy request to reduce our future workload? Should we really see which patient needs colonoscopy now and in future? And also what we do with it in terms of EMR and ESDs?
Sorry, in terms of?
EMR and ESD.
Okay, that's very good question. Very good question and difficult to answer. I think that it depends on the situation of the pandemics. If the pandemic is over, we can do the same we did. If it is possible to do EMR, because of the lesion allows to do EMR, I think EMR is better because we don't need hospitalization and the procedure probably in this context of pandemics would be safer. And but if the patient needs EMR because it is not possible to treat that with ESD, because if it is not possible to treat that with EMR, it is better to do ESD than to do surgery. It is more convenient for the patient. So I think we have to individualize the situation. Out of the pandemic, when the pandemic is over, that is the situation now in Spain, we can do whatever because we can do what is normally indicated.
So, Lex, the answer to your question is the reason we stopped doing EMR and ESD is because if they get complications like perforation and abscess formation, the patient has to come back to hospital and they might need intensive care support after needing surgery. So that's why EMR and ESD has been put on a low priority. So all these large polyps has been the recommendation has been to delay such procedures till the pandemic is either over or is under reasonable control.
Yeah, I agree. This is we can delay that procedure because they can wait normally for months. There is no problem with that.
So while we're waiting for more questions, Rodrigo, you performing endoscopies, and how do you find wearing full PPE and eye shields and then doing the procedure? Do you see that you're missing some lesions, or you feel that you're taking long, or you personally, your heart rate is going up by every hour of endoscopy you're doing?
It is more uncomfortable to do that with PPE, but probably that will be the standard of care for the future. Probably we have to be used to use PPE for doing endoscopy because probably we should do before that. We are now facing a dramatic situation that is opening our eyes about the low level of protection we did before. I think we have to use to that, and that's is here for staying with us for a long time.
Okay. Now coming back to Bartholomew, so rectal cancers a bit tricky because before that, unless they had a high risk features, circumferential margins threatened, we went on to resect those cancers. But now, even if it's a lymph node positive and it's T3, T4 disease, the guidance is to give them a radiotherapy. Yeah. So is there any benefit in that group of patients? Historically, wasn't.
Yeah, but I mean,
do you mean post-operative?
We do it.
Pre-operative.
No, pre-operative, in terms of survival, you are right. Yes. The impact of the pre-operative treatment in survival has not been clearly shown, but we know that the adjuvant, the post-operative treatment in colon improves survival. That is clear in case of lymph node involvement. So the problem of the real effect of chemotherapy, mainly chemotherapy, in survival in rectal cancer has not been yet clearly solved. But I think that is a personal opinion. We can assume that in case of lymph node involvement, the chemotherapy using both drugs, oxaliplatin and capecitabine, improve survival. That probably it would be better we have that have results of clearly designed clinical trial, but we have not these results. And nowadays, moving to the preoperative therapy, I think the Rapido trial that I mentioned was presented at ASCO that include all the treatment, all the chemotherapy treatment in preoperative setting, and that is a similar movement has been developed in the breast cancer. So I think the future may be the short radiotherapy that is easier for the patients. And full chemotherapy, all delivered preoperative, could be the future. And the Rapido trial show us that is not inferior, it's not even, it's a little bit superior, not significant, to the more classical approach with all the radiotherapy with concomitant capecitabine, mainly delivered preoperative. And that we have, in this way, we have not results or not clear results of the post-operative chemotherapy. And in the preoperative chemotherapy, the only results and the only benefit came from the capecitabine or 5-fluorouracil, but the trials using oxaliplatin preoperative has not been superior to the single agent concomitant with radiotherapy.
Excellent. There's a question about anticoagulation therapy. I think beyond my remit here is, unless Rodrigo want to comment,
Why not?
role of anticoagulant therapy in the treatment of COVID.
Yeah.
About anticoagulant therapy.
Yes.
Yeah, it is not clear point. It is known that COVID affects the coagulation cascade, and it has been some ideas about treating COVID patients with anticoagulants, but it has not been adequately addressed in the literature. There isn't any trial that compare anticoagulant with non-anticoagulant, so we don't have the answer for that question.
But
So
it seems, Rodrigo, that probably at the beginning we focus on only the respiratory failure. But if when we had sufficient data, the thromboembolic events emerge as a significant cause of mortality, of lethality in COVID patients. That is probably taking in mind, remember that we have no clear antiviral therapy. We need to move to the supportive measures. The supportive measures may be not only respiratory supportive measures, but trying to avoid the incidence or to reduce the incidence. But I fully agree with you, we have no clear data. But maybe one interesting tool trying to increase the support of the patient during the infection.
Okay. Well, thank you, all our participants. The questions are slowing down, so I'd like Rodrigo and Bartolomeo to conclude. So we start with Rodrigo first. If you can give your concluding remarks about the pandemic once it's going to be getting through and once it's over, what were your views?
So we as I said, we have to think about how to restart wisely, because the majority of countries we are more or less done with the pandemic, and the next point will be another challenge that probably will take longer, and we have to be also prepared for fixing that problem.
No, it's okay if I do.
Okay, so well, what your view?
Well, as Rodrigo mentioned, I think that in our center, probably the pandemic is now over, but we have seen, I don't show our data, but the reduction of patients referred to the oncology department in our center has been reduced in 38% in the last 2 months. That means that this patient exists, but we have a delay in the diagnosis that cause deferred healthcare use of the resources, and we will have the second wave in the following month. I am sure of that. The second wave, not directly caused by the SARS-CoV-2, but all the rest of the disease that cause the death at the same time. In this death due to the other causes like cancer has not been decreased, it remains.
I agree with Bartim. We've gone through a storm. We are waiting for a tsunami, and that tsunami will be a disease which has been left behind in the community, which will not only slowly start creeping, it will be start overwhelming us in the next couple of months. So that's the one dilemma. The second dilemma is that this disease is going to stay in the community for a little while. So we have to carry on with what we have done really well: personal protection, social distancing, protecting our elderly and vulnerable people. Also, all these things now will start embedding into our decision makings, whether this is diagnosis, whether this is surgery, or it is chemoradiotherapy. All this will start embedding vulnerability scoring, comorbidities, risk factors. Now we will be paying a lot more attention to those as we have not done it probably in the past. That'll be my remarks.